Hey Appy, learning with you hits different.
Learning what?
Chill, dude. I meant pancreas. Can we proceed to bowel next?
Sure, let's start.
Hey guys, welcome back to our channel. Today we'll be discussing one of the most important topics in a doctor's life. This disease is so prevalent that you take any subject, pathology, microbiology, biochemistry, medicine, surgery, pediatrics, radiology, whichever branch you specialize in, you definitely get one or two patients in a week of this particular disease. Now, tuberculosis affects the entire body from head to toe, but today we shall be concentrating mainly on the abdominal manifestations of tuberculosis. Now, as most of you know, the disease doesn't spare any age or any gender. However, abdominal tuberculosis is known to be more prevalent in ages of 15 to 55 years. It does not have any male or female preponderance. Coming to the predisposing factors, most of you already know these, however, we shall just brush upon it. The most common is poor socioeconomic status. Concomitant HIV infection is a very common thing that we find in cases of tuberculosis. Immunosuppressed states such as chronic kidney disease, chronic lung disease, patient on immunosuppressants, patients who are recipients of organ transplant, patients who are taking steroids, they are more prone to develop this disease. Coming to the pathophysiology of abdominal tuberculosis, there are four major pathways through which abdominal tuberculosis can occur. The first being dissemination from a primary focus in the lung. Second, ingestion of infected sputum of a primary focus in the lung. Third, it can be lymphatic spread from infected lymph nodes. And final, all of you must already be familiar with blood dissemination, that is hematogenous dissemination, also known as miliary TB. Now, the way we shall be discussing abdominal tuberculosis is we shall divide it into most common manifestations and then go to the rare manifestations. Most common being lymphatic, meaning lymph nodal TB, followed by gastrointestinal, that is bowel TB, and lastly the peritoneal TB. Then the solid organs, we shall have a word about that. So let's start with tubercular lymphadenitis. Now, as I already said, this is the most common form of abdominal tuberculosis, and the most common involved lymph nodes are usually the celiac, SMA, the upper para-aortic. The lower para-aortic are less frequently affected. Now, this is simple. All of you are already aware that the most common site of tuberculosis in abdomen is the ileocecal junction or the cecum. The draining lymph nodes drain into the celiac or the SMA group. Therefore, these are the most common involved lymph nodes. The lower para-aortic lymph nodes are not draining this part of the bowel. However, they can become involved in tuberculosis if the spread occurs from the fallopian tube, that is pelvic organs. Now we shall see the CT patterns of tubercular lymphadenitis. There are mainly 5 patterns. First being the peripheral rim enhancement with central non-enhancing core. This central non-enhancing core is necrosis. This is the most common pattern. Next, the heterogeneous pattern of enhancement. This is the second most common pattern, followed by homogeneous, then non-enhancement, and finally there is calcified lymph nodes. We shall see some examples to fortify our knowledge. Alright, you can see here that I have marked an arrow that this lymph node is showing peripheral rim enhancement with central non-enhancing necrotic core. Now, one thing I want all my students to remember is that TB lymph nodes, they conglomerate. They can be discrete, but many a times they conglomerate. They form groups and they form conglomerates, and if they are superficial, on examination, the surgeon or the medical physician feels that this is matted lymph nodes, whereas we see it like this. These are multiple lymph nodes that have conglomerated to form one lymph nodal mass, each of which is enhancing peripherally with central non-enhancing necrotic core. This is classical of TB. Look at the location. It is located in the right iliac fossa. Again, very classical of TB. the conglomerated lymph nodes, first thing that should come in your mind is tuberculosis. Now, next type of enhancement, here you can see by the arrow that this is showing homogeneous type of enhancement. All of these lymph nodes are along the SMA axis and they show homogeneous type of enhancement. Coming to the next type, here we can see that the upper para-aortic, they show heterogeneous type of enhancement. There is marked enhancement as well as mild enhancement, meaning heterogeneous enhancement in this type of lymph nodes. Coming to the next type, this is showing a calcified lymph node. This is usually the end result of tubercular infection. Now, not just CT, we should learn how MRI appearance is as well. So on MRI, these lymph nodes are T1 hypointense. The T2 status can depend upon the stage. They are usually hyperintense, but if they calcify, they become hypointense. Diffusion restriction, normally lymph nodes diffusion restrict, whereas TB lymph nodes also diffusion restrict owing to the central necrosis. Now on post contrast, again there are patterns. We have already discussed that peripheral rim enhancement is the most common type. They can also be uniformly enhancing, they can be heterogeneous enhancing. Now you know that peripheral rim enhancement is most common. We shall see it first on MRI. This is a classic example. Now you can see here by the arrows that there is a lymph nodal mass, meaning these are conglomerated lymph nodes. On T1 fat sat post contrast, you can see that each of the lymph nodes is showing peripheral rim enhancement with central non-enhancement, that is necrosis, as well as these are forming conglomerates. Whenever lymph nodes form conglomerates, think of tuberculosis. Coming to the next example, this is a classic example of homogeneous pattern of enhancement. You can see here on the T2 fat sat image by the arrow that it is showing T2 hyperintense signal, whereas on T1 post contrast fat sat, the lymph nodes are showing uniform homogeneous contrast enhancement. Now this case, you can see here that in the right iliac fossa on T2 fat sat, there is a conglomerated lymph nodal mass. On T1 post contrast fat sat image, these are showing heterogeneous enhancement. Now another point I want you guys to observe here is this. This is the cecum. It is showing symmetric wall thickening. This came out to be around 5 mm and the lumen is narrowed in center. There is surrounding fat stranding here. Now, this is classical of infective etiology. However, a close differential at this point of time is malignancy. Whenever you see wall thickening, though malignancy presents with asymmetric wall thickening, we do get cases where it simulates tuberculosis. So the way you differentiate is, even malignancy has malignant lymph nodes, that is locoregional lymph nodes. However, in TB, the locoregional lymph nodes form conglomerates. As you can see here in this post-contrast image, that there are conglomerated lymph nodes. If they show peripheral rim enhancement with central non-enhancing component, which is the most common pattern of TB lymphadenitis, you are almost certain that it is TB and not malignancy. So remember that TB can very much simulate like malignancy, both are close differentials. However, the pattern of enhancement and the conglomerated lymph nodal pattern is very, very important. This case is also very important because this is one of the most classic type you will ever get, that you have you have symmetric wall thickening in the bowel, locoregional lymphadenopathy that are forming conglomerates. This case we had given TB as the first differential. My gastrointestinal medicine fellow went with colonoscopy. He performed a sampling of the cecum. Zn staining was performed and it came positive for TB. Once we are done with TB lymphadenitis, let's now go to gastrointestinal TB. Gastrointestinal TB, this is the second most common pattern. You already know that the most common site is the terminal ileum or the ileocecum. Now, why so? There are multiple factors. One of them is largest amount of lymphoid organ within the bowel is in the terminal ileum and the ileocecum. So TB is a bacteria, in fact mycobacteria, that loves lymphoid tissues. Next, ileum has the longest transit time in our bowel. So increased stasis. Then there is maximum fluid and electrolyte absorption in this area. So TB, the more chances of it being absorbed in the lymphatic tissues. So by these regions, the most common site is the terminal ileum or the ileocecum. Let's see how it appears on CT. Now most of you are almost aware of this. I'll just brush up quickly. There is symmetric bowel wall thickening in the ileum or the ileocecum. Associated fat stranding is present, and we already seen an example just previously. There is locoregional lymphadenopathy. Now, if fibrosis is present, then there will be pulled up cecum. At this point of time, I want you to also remember that there are certain complications of bowel TB. One of them is if there is increased bowel wall thickening, it can even narrow the lumen and even lead to obstruction. Then, if the surgeon goes in, if TB is not controlled, even if the primary pathology, meaning the obstruction that the patient is presenting with, is resolved, the chances of adhesions recurs. This is because TB is not controlled. Now we shall see the MRI findings as well and then see examples. In MRI, we know that there is bowel thickening. This is T1 hypointense. Again, the T2 signal depends upon whether it is in the active stage or fibrostenotic stage. In the active stage, it is T2 hyperintense, whereas in the fibrostenotic stage, it will become T2 hypointense, which will show prolonged delayed enhancement. On post contrast, it usually shows heterogeneous enhancement in the active stage. Now let us see some examples again to fortify our knowledge what we have studied. Here you can see the first image is a CT. This is a typical classical example of bowel TB where the cecum shows symmetric wall thickening. Here there are surrounding fat stranding and the things that I have circled are enlarged lymph nodes. This on T2 is showing symmetric wall thickening. This was around 5 mm. You can see here by the arrow, symmetric wall thickening of the cecum. Lymph nodes are also visible over here. Then this is the pre and the post contrast T1 fat sat image. You can see on the pre contrast that it is mildly hypointense by these arrows. On post contrast, it is showing heterogeneous enhancement. So this was a case of abdominal tuberculosis. Coming on to the next example, again of bowel TB. This is a case which is showing terminal ileum symmetric wall thickening with surrounding fat stranding. The draining lymph nodes were also enlarged, which show conglomerated appearance. However, I have not included that in the image. You can also see here that the spleen also had lesions. Whenever you have multi-organ involvement, think of TB, think of malignancy. Coming on to the next, this was a case of fibrostenotic variant of TB where we can see that this is the ileocecal junction. This is pulled up. It is present in the subhepatic location. I have added a barium image to fortify our knowledge as well. This is the ileum and the ileocecal junction is highlighted by yellow over here, and this is present in the subhepatic location, meaning a pulled up cecum. Alright, having studied the two most common variants of abdominal TB, let's now go to the third one, meaning peritoneal tuberculosis. Now, this is usually not primary like TB lymphadenitis or TB bowel. This is usually secondary. Most common route of spread is hematogenous. However, lymph nodal disease or fallopian tube disease or rupture of any GI disease, or if the GI disease is contained, inadvertent surgery and then rupture can lead to peritoneal tuberculosis. Traditionally, we have classified this into three variants, meaning wet, dry, and fibrotic fixed type. In wet type of peritoneal tuberculosis, there is free or loculated ascites with presence of membranes. In dry type, there is mesenteric thickening, omental thickening, lymphadenopathy with multiple adhesions. And in the last fibrotic fixed type, you can remember this as either a mass forming or a cocoon forming variant. Now, though there are three variants, I want you guys to remember that it is not easy differentiating one from the other. If you find any of the variants, chances are that all three are mixed. So do not attempt to differentiate the variants. Just pick up that this is peritoneal tuberculosis, put the patient for sampling, obtain the sample, rule out malignancy. Your job as a radiologist is done. Do not try to differentiate each type, as usually it comes as a mixed pattern. That's why we'll study both CT and MRI appearance together. This is usually presented by mesenteric omental nodular thickening with surrounding fat stranding with plus or minus ascites with membranes. Now this nodular thickening shows enhancement on post-contrast imaging. Let us see some examples. Now you can see here by the arrows that I have marked that there is peritoneal thickening which shows subtle nodularity. Also anteriorly, this is peritoneum. Anteriorly, this is the omentum. The omentum shows nodular thickening. This is known as omental caking. You find omental caking in a patient, put differential diagnosis of tuberculosis. Another close differential is malignancy, definitely. CA ovary especially presents very frequently with omental caking. So you need to scroll through the entire scan to rule it out. Next, on T2, you can see here the omental caking is being highlighted. There is presence of ascites here in the entire abdomen, and there is omental caking. Again, CECT of the same patient at the lower section, I have shown peritoneal nodular thickening. And there is enhancement also. On T2 fat set, you can see that there are membranes within the ascites. This was a case of peritoneal tuberculosis secondary to bowel TB. Bowel TB was also there in this patient. However, I have not included in this particular example. Coming next, this is a classic example of omental nodularity with surrounding fat stranding with presence of ascites. So this is again omental caking, example of peritoneal tuberculosis. This is CECT example where we can see nodular enhancing thickening of the omentum. It has thickened so much. This was approximately 4 to 5 mm. So this is omental caking in a case of tuberculosis. Coming to the last example in peritoneal tuberculosis. Now what I want you guys to see here is, you can see that the bowel loops are clustered at the center of the abdomen. Now these are the bowel loops which are clustered at the center of the abdomen. Now these are being surrounded by a rind of tissue that is showing enhancement. Look at this. There is a membrane that is surrounding this particular bowel loops. Now this membrane was approximately 3 mm and the condition is known as abdominal cocoon or encapsulating peritoneal sclerosis. Whenever you find abdominal cocoon or encapsulating peritoneal sclerosis, two differential diagnoses must come to your mind. First being TB. The second one being if the patient is a known case of chronic kidney disease, he is on ambulatory peritoneal dialysis, they can get abdominal cocoon. Encapsulating peritoneal sclerosis. Now this is a very serious condition. The patient can go in for bowel obstructions. These are classic examples of closed loop obstruction, meaning the starting of the bowel and the end of the bowel is present within the membrane itself. You do surgery, remove the encapsulating peritoneal sclerosis, remove the membrane, again reconfirm that the bowel is viable, put the bowel back in the abdomen, suture and come. Primary disease is still not controlled. Patient again goes for encapsulating peritoneal sclerosis, ends up having multiple surgeries. So this is quite serious condition and must be diagnosed. As soon as you see bowel TB, rule out encapsulating peritoneal sclerosis. Make sure that there is no bowel, no rim of tissue that is surrounding the bowel to form a cocoon. Alright, having done the most common variations of abdominal TB, that is TB lymphadenitis, bowel TB, as well as peritoneal TB, let's have a small word about solid organ TB. Now in solid organ, there is liver, spleen, adrenal. These are the three most commonly affected. Now, what you have to know is hepatobiliary TB, it is not primary TB. It is usually secondary to either TB lymphadenitis or TB peritoneum or TB bowel. Now, the findings are there is hepatomegaly and there are three variants that we classically describe in hepatobiliary TB. The first is parenchymal type, second TB cholangitis, third serohepatic variant. In parenchymal type, there are three other variants, that is miliary TB, which is by far the most common form of hepatic TB. Next is the nodular, and third is the mixed. By miliary, I mean less than 2 centimeter nodules are present within the liver. In nodular variant, more than 2 centimeter nodules are present. And in mixed, both miliary as well as nodulars are present. The second type is TB cholangitis. This is rare. It is present by irregularly dilated biliary radicals with presence of calcification along the tract of bile ducts. Now the last type is the serohepatic variant. Now this is the rarest type of hepatic tuberculosis. This is characterized by multiple nodules that are present in the subcapsular location. By subcapsular I mean the glissons capsule that covers the liver. Multiple nodules are present in the subcapsular location along with thickening of the glissons capsule. This is so rare that only few case reports are present. Now, liver almost never occurs alone. It is along with TB lymphadenitis or bowel or with splenic TB. Now, splenic TB most common form is miliary TB and it does present with multiple nodules present in the spleen less than 2 cm and splenomegaly. Let us see some examples of hepatic and splenic tuberculosis. Here is a classical example. We can see here by these arrows that multiple tiny hypodense nodules are present within the liver and also spleen. On contrast, they are showing peripheral rim enhancement with central non-enhancing components which are necrosed, caseous necrosis. This is again similar pattern to the TB lymphadenitis which we learned earlier. On T2 fat sat, these are T2 hyperintense, which again you can see here that these hyperintense signal are showing peripheral diffusion restriction, peripheral post-contrast enhancement. Alright, having done hepatic and renal TB, let's go to adrenal TB. Adrenal TB, one of the most common causes of Addison's disease in India is adrenal TB. Now, bile TB involves the adrenal glands bilaterally and calcification is almost pathognomonic. Peripheral enhancement of lesion with preserved adrenal architecture is the classic description that we say for adrenal tuberculosis. Let us see an example here. We can see here on the CT that there is a peripheral enhancing with central non-enhancement lesion involving the right adrenal gland. You can see closely that the left adrenal gland is also affected and with a similar but smaller lesion. You can see here again on the coronal images that both the adrenal glands are affected by presence of a peripherally enhancing lesion that shows central non-enhancement. On T2 fat sat, the same pattern is observed and on post contrast again peripheral enhancement. Now this is a classic example, almost a spotter. This is tuberculosis, bilateral adrenal calcification. Now this is in adult. I have told in my previous class, the way you identified if given a spotter, whether it is an adult or child, is look at the vertebrae. If they show degenerative changes, more likely you are dealing with an adult. Now the same patient, this is undoubtedly tuberculosis. But if you get some 2-day, 3-day-old child and you get bilateral adrenal calcification, think of a congenital disease, that is Wallman disease. Wallman disease also presents with bilateral adrenal calcification, but this is in pediatric population. So now, having completed the module on abdominal tuberculosis, I hope all of you get a clear understanding and are able to diagnose abdominal tuberculosis in your day-to-day practice. This is a very, very important chapter and I want all my students to get a clear idea of tuberculosis next time they come across it. Thank you, everyone. Hey guys! If you like our simplified approach to difficult conceptual topics, please do comment, like, share, and subscribe to our channel.